Welcome back to our in-depth look at critical medical research. Today, we're going to break down some very important findings in colorectal cancer treatment, presented as a podcast. You're listening to our analysis of a significant original article titled Outcomes of Distal Rectal Cancer Patients Who Did Not Qualify for Watch and Wait, Comparison of Intersphincteric Resection versus Abdominoperineal Resection. This paper, co-first authored by Dr. Yael Pfefferman and Dr. Floris S. Verheij from Memorial Sloan Kettering Cancer Center, was published online on October 12, 2024. For decades, the total mesorectal excision, or TME, has been the gold standard for locally advanced rectal cancer. While TME often allows for sphincter-saving surgery, SSS, for tumors higher up, distal rectal cancers historically often required an abdominoperineal resection, or APR, leading to a permanent colostomy. However, advancements like neoadjuvant therapy, shrinking tumors, a reduced recommended distal resection margin from 5 centimeters to 1 centimeter, and improved imaging have broadened the options for SSS, making intersphincteric resection with hand-sewn coloanal anastomosis, or ISRCAA, a common oncologically sound choice for many distal rectal cancers. But here's where the landscape fundamentally shifted: the watch and wait WW strategy. This approach is for patients who achieve a clinical, complete response to neoadjuvant therapy, potentially allowing them to avoid surgery altogether and preserve their organ. In fact, up to 50% of patients with locally advanced rectal cancer treated with total neoadjuvant therapy, TNT, may achieve sustained organ preservation through this WW approach. This leads us to the critical focus of this study. What about the patients who did not achieve a complete clinical response to neoadjuvant therapy and thus did not qualify for watch and wait? This group, requiring TME surgery, is known to have a higher risk of local recurrence and distant metastasis. The researchers aim to investigate the oncologic outcomes of ISR-CAA versus APR, specifically in this modern cohort of distal rectal cancer patients who received neoadjuvant therapy but did not qualify for watch and wait. Their primary outcome was local recurrence-free survival, or LRFS. The study was a retrospective analysis conducted at Memorial Sloan Kettering Cancer Center, a facility with a well-established WW program. They looked at patients with stage 2 or 3 distal rectal adenocarcinoma who underwent either ISR-CAA or APR between August 2009 and December 2019, excluding those who qualified for WW. Let's dive into the key findings. The study included 67 patients who underwent ISR-CAA and 79 patients who underwent APR. The median follow-up was a substantial 61.1 months. The two groups were generally similar in terms of sex, tumor stage, grade, and distance from the anal verge, though APR patients were, on average, older. An R0 clear resection was achieved in 96% of ISR-CA patients and 91% of APR patients. Pathologic complete response rates were 15% for ISR-CAA and 8% for APR, which was not statistically significant. Interestingly, the ISR-CAA group was more likely to have received total neoadjuvant therapy, TNT, 57% versus 39% in the APR group. Crucially, a significant difference in local recurrence was observed. 19%, 13 out of 67, of ISR-CAA patients developed a local recurrence, compared to a much lower 5%, 4 out of 180, of patients 79 in the APR group. The estimated 5-year local recurrence-free survival, LRFS, was 79% for ISR-CAA and 93% for APR, p equals 0.04. indicating a statistically significant higher rate of local recurrence in the ISR-CAA group. Most local recurrences in both groups were also accompanied by distant metastasis. Despite this, the estimated 5-year disease-free survival, DFS, and overall survival, OS, did not differ significantly between the two groups. DFS, 67% for ISR-CAA versus 64% for APR, p equals 0.19. OS, 91% for ISR-CAA versus 83% for APR, p equals 0.08. It's important to note that 19%, 13 out of 67 of patients in the ISR-CAA group ultimately ended up with a permanent stoma. Reasons included salvage APR for local recurrence, 9%, patient request due to poor bowel function, 4%, and diverting stomas never reverted due to complications, 6%. So what are the implications of these findings? This study is particularly noteworthy as it's the first to report on the oncologic outcomes of ISR-CAA versus APR, specifically in distal rectal cancer patients who did not qualify for watch and wait at a center with an established WW program. The findings suggest that for these patients, ISR-CAA was associated with a higher risk of local recurrence compared to APR. This is striking because both groups had similar tumor clinical stage and distance from the anal verge, and APR patients were less likely to receive TNT. The 19% local recurrence rate for ISR-CAA patients in this series is noted by the authors as one of the highest reported in the literature for patients treated with neoadjuvant therapy and adjuvant chemotherapy. The researchers propose that this higher local recurrence rate in the ISR-CAA group may be due to the selection of patients with more aggressive tumors in the modern watch-and-wait era. In today's clinical practice, TME surgery is primarily offered to patients whose tumors do not fully respond to total neoadjuvant therapy, suggesting these tumors might exhibit a more aggressive biological behavior. Despite the significantly higher local recurrence rate in the ISR-CAA group, the disease-free survival and overall survival were not significantly different between the two surgical approaches. The authors suggest that both local recurrence and distant metastasis contribute to survival outcomes, with local recurrence potentially having a greater impact on DFS in ISR-CAA patients, and distant metastasis potentially having a greater impact on DFS in APR patients. It's also important to acknowledge the study's limitations. It was a retrospective analysis with a relatively small sample size, and there were some differences between the groups, such as more ISR-CAA patients receiving TNT and APR patients being older on average. The study also did not include functional outcomes or post-treatment quality of life. In conclusion, this study suggests that, in the era of watch and wait, performing ISR-CAA for locally advanced distal rectal cancer that does not fully respond to neoadjuvant therapy appears to be associated with a higher rate of local recurrence. This means the potential benefit of preserving the sphincter may need to be carefully weighed against the potentially increased risk of morbidity from a local recurrence and the need for reoperation. As always in medicine, further studies are needed to confirm these findings and help guide clinical decisions. That's all for this episode. Thanks for tuning in to our deep dive into the latest medical research.